Um, Professor Jonathan Weir-McCall is a professor of radiology, senior lecturer, and honorary consultant in cardiac radiology. Um, King's College London. I have been an admirer of his work since years. Jonathan, you were participating in the landmark Scott Hart trial. You are writing guidelines on transcatheter valve prosthetics, heart imaging, so many fantastic work. And I was always admiring your work and also your lectures about this topic. So we are very, very happy that you participate in our last lecture of this year's Grand Round series in cardiovascular imaging. Recently, you were also working scientifically on the topic of artificial intelligence, and we are very curious to hear about your opinion about if AI can make the difference or not. Thank you very much, Jonathan, for being here.
Wonderful. Well, thank you for the incredibly kind and generous introduction, and it's my pleasure entirely to be here with you all today. So here to explore, how do we use big data? How do we use AI in cardiac imaging? And is it impacting our clinical practice and impacting our patients? And this talk will be focusing on predominantly coronary artery disease. And whenever we think about coronary artery disease, we often think it's a disease of modernity. We evolved into our hunter-gatherer form, and then we industrialized and we started overeating, under-exercising, and smoking. However, we look back at mummies exhumed from pyramids going back as 4,000 years ago now, we can find coronary artery calcification within these mummies throughout this entire period, showing that atherosclerosis has always been a bedfellow of humans and is not just a construct of modernity. Now, whenever it comes to imaging coronary atherosclerosis, we've got a broad and diverse array of techniques to pick up at its various stages, from coronary artery calcium scoring, which just picks up the advanced calcific plaque disease, through to IVUS and OCT, which can pick up that initial intimal thickening. Sitting in the middle between these two extremes is, of course, cardiac CT, which allows us to pick up both non-calcified and calcified plaque alongside our more traditional metrics of coronary artery disease of stenosis. And the implementation of coronary cardiac CT in chest pain has been well ensconced by the Scott Hart trial, which showed that if we use this over standard of care, even out to 10 years, we have reduced major cardiovascular events in the form of reduced non-fatal and fatal myocardial infarctions. And it's fantastic that we have this level 1 data that justifies the implementation of cardiac CT within our standard workup pathways. However, randomized controlled trials, while being absolutely the scientific gold standard, do have some external validity issues. And this is a meta-analysis of an incredibly large number of randomized controlled trials looking at the replicability to real-world populations. And I apologize for the small numbers here, but the red box ensconces cardiovascular trials. And we can see that 70% of them exclude patients who have hepatic dysfunction. And in fact, an incredible 64% of cardiovascular trials exclude patients with cardiovascular conditions that aren't the primary cardiovascular condition of interest. And I don't know about you, but if I look at the patients that come through our scanners, very few of them have isolated single cardiovascular conditions with no associated comorbidities. So whenever we're considering real-world impact of trials, of interventions, we also want to be examining whether it's having the same effect that we would expect it to have based on these trials. This is the state of care within the UK, whereby we had the 2016 NICE guideline update, which essentially said that if you have typical or atypical angina or ECG changes suggestive of ischemia, then you should undergo a cardiac CT. But you can see this was not roundly well received across the cardiologist community, who felt this to be poorly reasoned and risky. You can imagine quite a lot of these folk come from a perfusion backing and weren't terribly impressed that perfusion imaging was no longer part of the diagnostic workup within the NICE guidelines. So to examine whether the NICE guidelines and Scott-Hart data was actually resulting in the national and societal impact that we would hope for it to see based on this wider evidence, we looked to the national imaging datasets within the UK. Every patient has an NHS identifying number, and this then links them throughout a multitude of data sets which are collected nationally, including our hospital episode statistics, which captures every patient admitted within the NHS within England, including their reasons for admissions, comorbidities, ultimate discharge diagnosis and medications. The Office of National Statistics, which records the death certificate, so the causes of death as written on the death certificate, and the digital imaging dataset, which captures all the imaging performed within NHS hospitals. So examining 6 years worth of data from this, we found almost 3.5 million diagnostic imaging tests had been performed. And after exclusion of those that couldn't be linked to NHS number identifiers, an exclusion of cardiac exams not performed for the assessment of coronary artery disease, this left us with 1.9 million imaging exams to include in the final analysis. And over the study period, we found that there was a rapid growth of cardiac CT starting with the NICE guidelines in 2010, which recommended for cardiac CT usage in low pretest probability patients, and with a further, much more rapid uptake following the 2016 NICE guidelines, with the dashed line there representing 2017, whenever the guidelines have had a little bit more time to be disseminated. And in line with this, we saw a 25% average growth in cardiac CT and a 4% per year fall in the utilization of SPECT. Now, it's all very well saying that these changes could be ascribed to the guideline, but, you know, there are many other things going on simultaneously in the country. So is this a cause or an effect? And this is where time series analysis come in. What time series analysis allows us to do is look at the data trends before an intervention is put into place. And based on the time series trends before that interjection, we can then model out the growth rate that or the change rate that we'd expect to see following the intervention had that intervention never occurred. We can then compare this to the actual changes in utilization to see if these are different than would be expected simply from modeling historical trends. And what we find here is the grey line is the expected trends had the NICE guidelines not come in based on the historical growth rate prior to the guidelines coming out. And we can see that the increase in growth in the use of cardiac CT was much more rapid following the guidelines than would have been expected. We also saw a more rapid fall in the use of invasive coronary angiography than would be expected based on historical trends. So real impact of the guidelines on the utilization of these tests. And within the UK, we are split into a diverse range of healthcare systems, all of which are operating largely independently from one another. And this creates a great degree of natural variability, both in terms of test utilization, because of course, some centres have greater ability to increase their use of cardiac CT, Some will be buying new equipment, some will be hiring staff, but these are all occurring at different times in different centres. We also see the exact same heterogeneity in outcomes. And this allows us to examine, is there any differences or similarities across centres that are seeing more rapid growth in CT or slower growth in CT? And as a brief diversion before jumping into those, this is the people who were awarded the 2021 Nobel Prize in for finance, and essentially they won it for their work on natural experiments, whereby they looked at things that are traditionally incredibly hard to examine in economics, such as what happens if we change the minimum wage. And this is one of their most famous papers that ultimately led them to winning the Nobel Prize, where they said, well, we've got multiple states in the US. They sit directly next to one another. They've got very similar baseline characteristics, similar rates of employment, similar rates of wealth and deprivation. But in one of these centers, they've suddenly changed the minimum wage. And this was always argued against in the US, much more so than here in Europe, that if you increase the minimum wage, you will reduce employment because firms will shrink. They'll have to cut their workforce to compensate for the fact that the people they are hiring are more expensive. But whenever they examined this and looking at the employment rates both before and after the introduction of the change in minimum wage, you can see a very stable agreement between the two states in terms of level employment pre-change in minimum wage, as well as in post-change in minimum wage. And this is called a natural differences in differences approach, which is now heavily used following the development that these people put into it to examine as things change naturally across different states, what is their association with outcomes? So we see here that we have that natural variability and shifting in trends with time that would allow for this kind of natural experiment to occur. And whenever we examined just this, looking at centres in which cardiac CT grew more rapidly, we see more rapid falls in cardiovascular death in those regions. Similarly, we see a trend, but not quite significant, for reductions in all-cause mortality in regions that saw greatest growth in cardiac CT. Now, understandably, many people did point out that, is this a true cause and effect? And, is it simply that wealthier centres with access to higher-end technology have more cardiac CT and also have greater ability to implement other interventional changes that might result in better outcomes? And it's a very fair point. So we looked at an even more expensive test. We looked at cardiac MRI, which is much more expensive, much more restricted to wealthier university centres and cities. And we found no such association between the change in usage of cardiac MRI across these centres with the change in cardiovascular mortality across these centres. So this very much does appear to be a cardiac CT specific moderator of outcomes. And of course, while correlation does not equal causation, we do have the Scott-Hart trial that suggested that we should see exactly this impact. The limitation of the Scott-Hart trial, of course, was that almost all of the difference in the arms of the study were powered by non-fatal myocardial infarctions. The current large-scale countrywide study simply extends these out into the hard cardiovascular outcomes, confirming that alongside the reduction in non-fatal MIs that we expect from Scott-Hart, we're also seeing a reduction in fatal cardiovascular events across the regions with greater usage of this technology. Now, the diagnosis of stenosis and of coronary artery disease is just the beginning of the journey for the patient. Here we have a patient with extensive coronary plaque in the proximal to mid-LAD with an intermediate stenosis there. And the question at this point is, of course, should this lesion be revascularized? And the challenge with standard traditional anatomic measures is they show a poor relationship with flow across these lesions, such that 1 in 5 moderate lesions at 30 to 50% will be flow limiting. whereas 1 in 5 patients above or lesions above 90% stenosis will be non-flow limiting. And this is where more advanced technologies start to come in, such as CT-FFR, bringing our traditional anatomical assessment with CT into a functional assessment with CT-FFR. And this is very much an approach that has been sped up and driven forward with artificial intelligence technologies, both underpinning the extraction of the 3D coronary models for then plugging into CFD models, or for entirely AI-based approaches. And this technology has been shown to be highly accurate for the diagnosis of flow limitation across stenosis at a vessel-specific level. It's more accurate than PET, cardiac CT on its own, and SPECT, as we see from the Pacific trial here. Going back to that lesion then, we see that this was significantly flow limiting. So not only do they have a high burden of plaque, but they've got some functionally significant stenosis in their proximal LAD. And this is, of course, confirmed on the invasive coronary angiogram. You can see the pre-intervention image on the top right there, followed by the post-stent imaging on the bottom right. And again, we now nicely have randomized controlled trials that show whenever you deploy this technology, that it results in stable costs. It is safe in that major adverse cardiovascular outcomes remain unchanged between the standard of care arm and the CT and CT-FFR arm. But we do see a 20% reduction in invasive coronary angiograms. So once again, the question arises, what happens in the real world? And there were several challenges within the UK, and I don't know what it's like with yourselves in Switzerland, but NICE assessed this technology shortly after the initial chest pain guidelines in 2016. They did an analysis of it in 2017 and said this intervention or this technology is cost effective and would save the NHS money due to the reduction in downstream invasive coronary angiograms. The only problem with it was it's so incredibly expensive that none of the hospitals wanted to put up the money for it, not least because there was a number of perverse financial incentives for them to not perform the scans, not least that often it was the radiology departments who were having to pay for the scan, but it was the reduction of invasive coronary angiograms that were reducing the cost. So the cost savings were being seen out with the department that was having to pay for the technology. And at a hospital level, the cost savings weren't being seen because they are actually paid for doing invasive coronary angiograms, even diagnostic ones. So by doing less invasive coronary angiograms, they were losing money for that, as well as losing money for paying for the technology. It was at the next level up from the hospitals, the NHS itself, that would see the healthcare savings. So as a result of this, in 2018, the government centrally paid for the access to this technology such that it would not come out of the individual hospital budgets. Which again, as we saw earlier in our discussion of natural experiments, creates a ripe situation to compare behavior without the technology versus the behavior with the technology. As a result, we went out to the 27 hospitals that got access to this technology and asked them for provision of all the CT scans or the data of all the patients who had a cardiac CT in the 2 years leading up to the access to this technology and in the 2 years after the access of this technology, linking it through those national data sets back into their outcomes. So this is big data. We were working with 4.7 million healthcare records across 90,000 patients, lots of outcomes, 4.5, almost 5,000 deaths, 480,000 hospital admissions. So real opportunity to understand what impact we're seeing from the introduction of this technology. Now, not all trusts got access to this technology. In part, you had to be doing 500 cardiac CTs a year to qualify for access to it because they did want to ensure that adequate expertise was in situ to allow its interpretation and usage, but also because you can see the rate of deployment of the technology across our hospitals here, which certainly highlights one of the challenges of AI, is it's all very well saying this works, but actually getting the hospital infrastructure, the confidentiality groups, the IT departments to actually set up the nodes and the infrastructure to enable access to the cloud-based solutions is in itself challenging. And you can see some were straight off the mark within a couple of months. And you can see on the far right that even a year after or almost 2 years after the technology was deployed, as some of the hospitals are only just kicking in. And I can promise you there are many, many dots off the side of that. There was a neighbouring hospital to where I worked at this time, just a little down the road, and it took them another 3 years beyond this. Despite starting in 2018, it was 2023 that they finally deployed the technology. So this is a description of the cohort split between pre and post CT-FFR becoming available. So 35,000 patients who had a cardiac CT in the 2 years before the technology was available, and 55,000 after the technology became available. Now, of course, not everyone got a CT-FFR. It was only where clinically indicated. So we see about 8% of the cohort ultimately undergo FFR-CT here. There were very small differences, statistically significant, but clinically insignificant. A 1 year age difference between the pre and the post era, and a slight shift in the prevalence of heart failure and aortic valve disease there. And as the randomized controlled trials would have suggested, we did see a significant reduction in downstream diagnostic testing, with this being driven predominantly by the reduction in the utilization of second-line SPECT scans, as well as in stress echoes. We saw a very slight uplift in stress MRIs and viability MRIs, which will have partly offset the nuclear medicine reduction, but overall, much less diagnostic testing. We also saw a significant reduction in invasive coronary angiograms, and of those who did go to the cath lab, there was a much higher revascularization rate than there was in the pre-CT-FFR era, where just the cardiac CTs or cardiac CT plus stress tests were being used to inform the referral pattern to invasive coronary angiography. And this is the cardiovascular outcomes of this cohort. And you can imagine how intrigued we all were whenever the first batch of analysis rolled out with our log rank test, suggesting that there was a reduction in all-cause mortality and cardiovascular deaths, alongside a significant reduction in invasive coronary angiograms. However, the statistician kept us honest and ensured we performed an adjusted Cox regression analysis, adjusting for all these small differences between the populations. And after adjusting for these, we can see that the introduction of the technology is safe in that death and cardiovascular death do not change, but nor are they reduced. But even after adjustment for all the comorbidities, we see a significant reduction in invasive coronary angiography and a significant reduction in invasive coronary angiography without revascularization. Now, we go to another patient here to exemplify an ongoing challenge within CT-FFR, namely, where do we measure it and how do we interpret it? Because here's a patient with a moderate lesion in their proximal LAD, with a second moderate lesion in their mid-LAD. And if we look at the post-stenosis CT-FFR, this is not flow limiting, we're getting a value of 0.84. But if we look at the distal-most vessel, this drops down to 0.77. And there's quite wide variability across centres and across reporters as to which of these they'll report and to which they'll ascribe the greatest weight. We do have the Dan Nikad study from a couple of years back now, which included 110 patients with at least 150% stenosis in their coronaries, in which CT-FFR and cardiac MRI were performed. And they looked at an analysis of the distal vessel accuracy as well as the post-lesional accuracy. And if we focus first on the distal vessel accuracy, we can see that while it's not quite statistically significant on the far right there for the accuracy, that the overall accuracy of FFR-CT at 61% is quite a bit lower than that of stress CMR at 74%. As expected, stress CMR is less sensitive, but much more specific than FFR-CT. However, if we look at the post-stenosis value rather than the distal vessel value, we see identical accuracies across the two techniques there with an accuracy of 74%. Both are, of course, much lower than the historical literature would lead us to believe, but that's because this has focused on the hard lesions, those intermediate stenosis, excluding all the easier ones that are very clearly flow limiting or very clearly non-flow limiting. Again, with a trade-off between sensitivity and specificity between the techniques, but you can see the detrimental impact that inclusion of that distal vessel has in terms of interpreting is a lesion flow limiting or not. And another area that has received increasing interest is in the, apologies, it's trying to play in the background here. I'm hoping you're not hearing that, and apologies if so. It'll stop in just a second. So we have this potential for delta CT-FFR across the two. I don't think I can stop the background. There's sincere apologies. I can't stop that playing there, so apologies if it is interfering with you. But delta CT-FFR is an alternate approach that's been put forth for the assessment of the significance of a lesion, with some accuracy studies suggesting that a large delta CT-FFR of 0.12 both better predicts lesions that are hemodynamically significant, as well as identifying lesions that can be intervened upon with subsequent symptomatic improvement. And indeed, if we look at the Orbita 2 trial, where they looked at disease focality and likelihood of response to percutaneous coronary intervention, we see that the more focal the disease is, the greater the response they have to PCI, both in terms of their angina frequency and in their exercise tolerance time. So what happens whenever we look at their outcomes? So whenever we looked at the patients who had clinical CT-FFR indicated and performed within the wider FISH&CHIPS study, which was performed in 7,800 patients out of the 55,000 cardiac CTs, we can see a gradation in outcomes across post-stenosis CT-FFR values. We see no difference in grey zone value outcomes. So if your CT-FFR is between 0.71 and 0.8, outcomes are largely similar to those in whom the CT-FFR is greater than 0.8. Risk of cardiovascular death and indeed all-cause mortality goes up once you get below 0.7 and rises even more sharply whenever your FFR-CT falls below 0.5. Whenever we look at distal vessel outcomes, again, we see a very similar pattern and trend for myocardial infarction, cardiovascular death, and all-cause death, such that, again, very low values associated with worse prognosis, whereas grey zone values associated with similar prognosis to normal CT-FFR. So how do they both compare then in terms of predicting outcomes? And we see that in terms of predicting myocardial infarction, the model fits as seen by the AIC here are significantly better for the stenosis-specific FFR-CT value, but very similar for cardiovascular mortality and all-cause mortality, but much better for determining the likelihood of subsequent revascularization. So a stenosis-specific value appears to both be more accurate for determining hemodynamic significance, as well as better determining myocardial infarction rates. Whenever we look at discordant values, so we're focusing here purely on patients with a negative post-lesional CT-FFR and looking at the patterns of concordance in the distal vessels FFR. And we find 1 in 3 patients who have a normal post-lesional CT FFR who will have an abnormal distal vessel FFR. Now, when the values were borderline, so between 0.7 and 0.8, there was no difference in values or no difference in outcomes, whether your distal vessel was positive or not, whenever it was only between 0.7 and 0.8. But once the distal vessel value dropped below 0.7, even in the presence of a normal post-lesional CT-FFR, we do see an increased risk of MACE. Now, the diffuse vessel-specific values here do tend to be driven by diffuse plaque. So this is perhaps a surrogate measure of diffuse small stenosis diffuse disease. And mentioning plaque, and I realize we're half an hour in now, so I'll cover this briefly, but we are now hitting a stage of allowing routine automated whole vessel plaque quantitation with new AI technologies, because numerous studies have shown the benefit of quantitative coronary plaque analysis, the predominant challenge of this being each of these analyses across most of the studies included in this meta-analysis were taking anything from 20 to 40 minutes of human labeling to quantify. In addition, because of the challenge of analyzing this data, there were issues in generating sufficient population sizes to examine the impact of plaque on outcomes. And in this meta-analysis of 15 studies, most studies included revascularization as an outcome in order to increase their number of MACE to adequately power them. Most studies dichotomized the plaque burden, so it was either greater than or less than the median, and often with wide confidence intervals due to the limited number of events. So with the opportunity of AI deployment within plaque analysis, we can finally start to examine these questions on a much grander scale. And we have the initial early validatory studies of the impact of automated quantitative coronary plaque assessment versus the gold standard here in the REVEAL plaque study against IVUS, showing incredibly strong agreement in plaque burden between these two approaches. Within the 2 centres worth of data from the FISH&CHIPS study, we've examined this stratifying plaque into stages in the same way as we do for coronary artery calcium scoring. Stage 1 to 4 representing ever-increasing burdens of plaque, following these patients up for cardiovascular death and MI. And as the wider literature would expect us to believe, we see greater volumes of plaque as patients age. We see a greater percentage of that plaque being calcified the older you are. And whenever we look at clinical outcomes, we can see gradiated increased risks of both all-cause mortality, cardiovascular mortality, myocardial infarcts, and a composite as we go across the increasing plaque burden stages. Although across all these analyses, we see that those with the lowest plaque burden, so less than 100 millimeter cubes of plaque, the outcomes are largely similar. We can see a trend towards there being an increased risk, but this certainly didn't reach statistical significance. And this is only the beginning of our analysis of what automated analysis of the coronary skin yield, and this comes from our colleagues in Oxford, just down the road from us, which looks at perivascular fat, again yielding the large-scale data within the NHS digital infrastructure to examine the prognosis of PCAT within cardiac CT, and we see markedly increased risk of cardiovascular events in those who have elevated Phi values there. So at that point, thank you all for your time, and I certainly welcome any questions you might have. Thank you.
Thank you, Jonathan. Fantastic overview and excellent presentation on various topics regarding coronary artery disease imaging. Okay. There are some questions in the chat. For example, the first one, I think it refers to the data that you showed for the UK, the number of examinations over the years. And here the question is, why has ICA remained relatively stable in growth despite the rapid rise of CTA? Also, is CTA replacing SPECT more than it's replacing invasive angiography? Or is it just an increase in the total?
I think all excellent and interesting questions. We did see a small reduction. It wasn't large, but we did see a small reduction in invasive coronary angiography in those with following the NICE guidelines whenever we saw the most rapid uptake in cardiac CT. And certainly one reason, at least in that early phase, for it not seeing a reduction in invasive coronary angiography is the earlier NICE guidelines said we should only be using cardiac CT in those with a low pretest probability, much like the old ESC guidelines as well. And if that's who you're doing all your cardiac CT in, very few of those are going on for invasive coronary angiography, and therefore there's very little possibility of impact. The second factor is certainly we have a background low rate of direct to invasive coronary angiography referral in stable outpatients within the UK. It's predominantly invasive or non-invasive testing and cardiac CT that was being used. And therefore, a lot of the invasive coronary angiography being done is for MIs, and background rates of MIs in an ever-aging population are going to be relatively stable. So we have a possibility of helping reduce invasive coronary angiography, and we did see a small reduction in that. But there is going to be a threshold effect as to how much we can impact the total invasive coronary angiography burden within the country, given that it is used in STEMIs, non-STEMIs, etc.
Okay.
But we did see a marked reduction in SPECT examinations, which would be the study that we would expect it to have the greatest impact on, because people were slowly shifting from functional assessment of patients with stable chest pain to an anatomical assessment with CT for those with stable chest pain.
Okay, thank you. There is also a question regarding data management. What is the most challenging aspect of data management between cloud and on-site? So, especially when it comes to dataset federation privacy. That's, of course, an important question.
Yes, fantastic question, and slightly differing answers, I suppose, depending if you're talking clinically versus research-wise. Focusing first on the clinical front, that was certainly one of the key barriers to the expansion of services within the UK following the introduction of CT-FFR. There were lots of concerns on data security, and part of that was got round by having a centralized hub for all hospitals to send their data to in London, which then de-anonymized it, pushed it to the States, because that's where the cloud is hosted for the analysis of these cases, before then coming back via the central hub in London and percolated back out to the remainder of the hospital. So this was how we dealt with the fact that many of these AI clouds aren't hosted in the UK, and therefore you have that requirement, GDPR, for protection there. In terms of research, yes, things get even more challenging. Still, depending on whether you're using prospective consented data, in which case things become much easier, versus this retrospective unconsented data. And we are using quite a bit of federated learning, particularly when working with other countries outside England. So whenever we're working with China on developing and testing models, both their country and ours are very restrictive in how data can move across borders, and therefore federated approaches are much more achievable within this. It does present some challenges in terms of data labeling and gold standards because it's hard to get a central core lab adjudication of that. But it's better than only having your own local data sets to work on. I hope that answers what you're asking, but please follow on if there's more details that you're looking for in those answers.
Yeah, thank you. Thanks, Jonathan. Yeah, this the topic will never stop. I think this will accompany us in all our work clinically, but research. There is another very interesting but more radiological, let's say, question regarding HU values, since they are known to shift with two voltage, contrast density. How do such tools, AI tools, standardize its segmentation across different scanners, scan protocols to prevent misclassification? Here in the question, it is about, for example, plaques, necrotic cores, 30 ounce units, for example. But certainly the same question is also valid when we look at analysis. So I wonder what your opinion about.
Yeah, I think such an important question and such a huge challenge to the field of quantitative imaging as a whole here. I think it's probably why we've seen the most consistent predictive value of total plaque volume versus the subcomponents because of this issue of drifting Hounsfield unit values. Some studies show incredible importance of the low attenuation plaque. Other studies have failed to replicate that. And I suspect it is going to be around the handling of Hounsfield unit values with shifting KVs and different scanner models. You can provide some adjustments using intraluminal contrast, and certainly I think most of the big solutions out there provide an internal adjustment to the Hounsfield units, either within the aorta or within the coronary. It's not universal, but it does help slightly adjust for that. And with big data, you can then also adjust in the background for scanners. And I know that's what Caristo's PHI solution does to account for these drifting Hounsfield units. But it does present further problems whenever doing longitudinal assessment. So I think we provide relatively robust values on a single assessment. Your values may go up or down a bit, and you're going to fall into roughly the same risk envelope with these small values. The challenge becomes when you're trying to follow people up longitudinally and say, have they responded to therapy? Are they progressing at an acceptable level or an accelerated level? And if we know that the values can shift by 25 to 30% if you scan them twice on the same day, and indeed that's what a lovely study from Bjarne Norgard showed it was indeed the case whenever they scanned people in the morning and afternoon. How therefore do we interpret longitudinal assessment? And they kept the scanner acquisition parameters the same. So that will only be magnified if you're scanned on a different scanner with different settings at 2 time points. So I think it's an area we're really going to have to knuckle down on in the community if we ever want this to be a tool that's to be used for more than a single time point analysis. Photon counting CT may provide a significant solution to that. The virtual monoenergetic reconstruction certainly help with that HU stability, as well as giving us greater image resolution so that we have greater confidence where the plaques are. But this is largely hypothetical at the moment. We do still need to see what variability is like whenever we scan twice and longitudinally with this new generation of scanners.
Yes, I fully agree with your statement. I think particularly photocardiac CT will perhaps help on the one side, but it also introduces new issues. I mean, a higher resolution means more data, which is perhaps just by statistics and variability. And the more energetic is a good thing, but we also know the monoenergetic energy level determines, the Hounsfield number. So thresholds need to be adapted to respective monoenergetic levels in photon counting detectors. So many new challenges ahead. You certainly are aware of the variability of the, let's say, early AI tools for coronary plaque quantification. I think was a very nice example by, I think it was Korn Niemann in JCCT some years ago, showing that there is, for one the same data set, 7 AI tools, and they found, I think, variations 300 to 400% in certain plaque parameters. So we have also a tool. We have a tool from of our CT machines, and we noticed also, segmentations. This can be done by the machines as they do it, but it could also be done a bit differently. I had the impression, at least in my experience, that these tools segment a bit too much. Every vessel wall is, somehow contains half a millimeter larger than the others. They overestimate compared to my visual impression, the total plaque load, and again we heard that the tools differently on the same data set. So how should we manage that? What can we do to standardize this and make it more comparable?
Yeah, it's going to be an interesting, I think, challenge. And like you say, with multiple AI vendors out there, each quantifying these things in slightly different ways, how do we translate that into low, medium, and high risk? And, this may be through a variety of approaches, whether we have a singular data set that they all analyze and we can provide a weighted adjustment of the volumes back to a standard universal weighting, or whether we move to an outcome based thresholds, and every manufacturer has a threshold that defines a 1% 10-year risk, a 5% 10-year risk, a 7% 10-year risk, so that we at least know what those particular thresholds are for the different manufacturers. I don't see us getting over the issue of variability in measurement anytime soon, not least because every manufacturer's got a completely competing solution to this. And that's only going to grow as we see new technologies come on the market. So if we try to regress everything back to the null, we'll end up in the same situation as coronary artery calcium scoring, where we're locked into a standard set by electron beam CT and unable to yield any of the advanced knowledge that we've gained in calcium scoring over the last 30 years since that approach was standardized, including our weighting of the plaque density probably in the wrong direction, where we give more weight to more dense plaque when we know that the less dense plaque is the greatest risk, but we're locked in there. So this is probably a nice historical lesson that we want to avoid by being overly formulaic in our application of plaque quantitation, but we do just need to be cognizant of how we interpret the outputs of these different models and not assuming all are equal.
Yeah, exactly. Thank you very much. I fully agree with your opinion on that. So, I don't know, Robert, do you have a comment, perhaps? A question?
No particular. So also thank you from my side.
Can't hear you well, sorry.
You can hear me well? Maybe better now?
Yeah, it's better now.
Okay, so I need to move closer to the monitor. So yeah, no particular. Thank you, Jonathan, for these very nice data and the complexity of handling so much data and getting out the right information, and also the difficulties in dealing with the different data sets and aligning this with the AI perspective. So this was clearly very wonderful. So I don't have any further question. I think you showed it all, and also the questions were brilliant. So thank you very much. So this is all from my side.
Yeah, then I think we are ready to close the session. Thanks again, Jonathan, for being with us. Excellent presentation, excellent discussion, excellent outlook into the near future. So now everybody is welcome to start the summer holidays. And in the middle of September, we will continue our Grand Round series, the 5th one, then, and we will let you soon know the exact program. So thank you, everybody, for being with us. Thanks, Jonathan.
Wonderful day, and been a pleasure. Thank you.
Thank you very much.
Bye-bye.